that marker, and you know that the patient will respond in like 95% to a certain drug. Unfortunately, we basically don't have those biomarkers. So for the time being, it's often a trial and error. However, as I said, the therapy with belimumab is very effective. So at least in my experience, in a high number of patients, the drug works very well.
Okay. Got it. So you mentioned, usually the patients are musculoskeletal or have like joint involvement. Have you used Benlysta on patients who have like skin rashes or any of the other organs involved?
Yes, I've used it in patients with skin rashes. I've used it in patients with muscle disease. And, it works reasonably well, though I tend to keep it really restricted to those patients where really the musculoskeletal manifestations are really the most important part of the disease. As I said, I don't use it or try to avoid it in patients with renal disease unless it's a very unless it's like lupus nephritis type 1. Well, I think I also had one patient in type 2 lupus nephritis, but those are exceptions. So I really restrict it to those patients where musculoskeletal involvement of the disease is the most prominent part of the disease manifestation.
Okay. And was just curious, like how you determined that patients with musculoskeletal involvement were the right patients. Was that from the study? Was it just from your personal experience? How did you determine that
all of them,
these are the characters?
Course, that's how the drug was approved for the disease with the studies that I mentioned earlier. And that's my experience that it was well. It's also the experience of my colleagues. I mean, it's, I remember many years ago when the drug was approved, that of course was a big issue at the rheumatology meetings. It's and still in lupus meetings, it's a big issue because again, there are not that many drugs approved for lupus.
Yeah.
And for example, if I want to prescribe rituximab, I always need to get to make sure that the patient's insurance will pay for the rituximab. Whereas if I want to prescribe belimumab, I can prescribe it to every lupus patient without any pre-approval by the insurance because it's an approved drug.
Okay, that makes sense. So with your patients who are on Benlysta, how many or what percentage of them would you say started Benlysta right after they stopped responding to steroids and Plaquenil versus tried an immunosuppressant like methotrexate or something else first?
Oh, I would say still the majority of the patients have tried one other immunosuppressant, again, be it methotrexate or leflunomide, or again, in selected cases, Imuran. That's probably 60 to 70%, and the remaining 30 to 40, maybe rather 30. So it's like 1/3 of the patients who have so severe disease that I stopped basically after the antimalarial drugs directly with belimumab because I don't want to waste any time in those patients.
Okay. So I know you mentioned earlier that, you weren't a big fan of immunosuppressants like methotrexate and Imuran. So I was just curious why you put patients on those